To chair our next session, I would invite Professor Raj Baveja. Professor Raj Baveja. Dr. Sushma Sinha. Dr. Aarti Sharma. Please come and chair the session. The speaker for this session is Kathleen Hoeger. She would be talking about, are women with PCOS more stressed? We talked about how to tackle stress, and now let's know, are the women with PCOS more stressed?
So I want to thank everyone for the invitation. I've been enjoying actually a lovely vacation with my daughter in India. We were having really wonderful, relaxing, no stress. So it's been a very important time for us to think about the international treatment of PCOS, because one of the things that will be coming out, and we'll speak on tomorrow, is how as an international community of people who treat women with PCOS, we should be dealing with all of the same issues with all of our cultural differences. So I want to share with you today some of the data behind where we are with depression and anxiety in PCOS. So we'll review the prevalence of mood disorders and anxiety in PCOS and the impact of treatment on the prevalence of this, as well as the international guidelines. So as you all know, if you're in practice, you realize this intuitively. There is a clear association between poor emotional well-being and PCOS. The guidelines we'll be talking about is focused on improving the screening and detection, as we were talking about in the panel, of disorders which affect emotional well-being and that are commonly seen in women with PCOS, both seeking fertility and not seeking fertility. So we know that as a community throughout the world, there is an underappreciation of the amount of stress that these women are experiencing. We don't know what tools to use to address, and we'll talk about those, and we don't know the best treatment options. So if we think of this as a broad-based quality of life, we use that term a lot, quality of life. It's really made up of all the pieces below: the anxiety and depression, poor body image, psychosocial dysfunction, and eating disorders, all of which control and contribute to the quality of life. So we use mood disorders. Specifically, we base them on the diagnostic manual, the 5th version, and it's defined as major depressive disorder, dysthymic disorder, dysphoric mood dysregulation disorder, premenstrual dysphoric disorder, and depression not otherwise specified. So these are all of the things we screen for. The prevalence of this mood disorder, depression disorder, in the worldwide population is 3 to 18%. So depressive symptoms and depression are clearly more common in women with PCOS, and this includes those who are complaining of daily fatigue, sleep disturbance, which are the most prominent symptoms. The meta-analysis suggests that depressive symptoms are much higher in women with PCOS, 44% versus 17% in control women, and this is controlling for BMI. In addition, the severity of depression is much greater in women with PCOS. So the overall rate of depression is higher, but the degree that is moderate or severe depression is also higher. In this meta-analysis, you can see that all of the studies, with the exception of one, significantly show that PCOS women have much more depressive symptoms. And again, as I showed before, in the meta-analysis, we see most of the studies also show that this depression is much more severe, 4-fold higher. They are both from the clinic and community-based settings. So it's not just women presenting to your office, but also women who may not present that were screened with surveys. I think we can safely say it's about 4 times higher. So what features of PCOS are indicative of depression risk? We can't really show any differences between those who are infertile, having trouble conceiving, versus those who are fertile. They have the same risks of PCOS in most studies. However, there are some in a Chinese study that showed the infertile women had a little bit more. There's also slight risk with women who are more hirsute, so more significant depression in women who have hirsutism. And there may be some indicative risk that if you have metabolic disturbance, such as diabetes, you are also more at risk. But these are very small. Does obesity lead to depression? It is clear from the studies that women who are obese, about 50%, have higher odds of depression than women who are of normal weight. What about anxiety? Anxiety symptoms are highly prevalent. Again, meta-analysis suggests 5 to 6-fold higher incidence of depression and higher rates of severe depression, of anxiety rather. So this is very similar to what we see with depression. So if we look at general studies in population in Western Australia, they have also high rates, not as high as those presenting in the clinic. What about the features, again, of PCOS and depression? Hirsutism and androgen levels do not appear to be associated with PCOS anxiety. However, in the animal model, women are maternal androgen exposure. So if you give monkeys or rats testosterone prenatally, the pups that are born are much higher anxiety levels. So this is something intriguing, and we are looking at this very information in a study we are currently doing. What about body image? Body image is the way a person thinks and feels about their body, including their appearance. So factors like weight, hair growth, acne, and self-esteem, and then sociocultural factors that impact how one thinks about their body. When we look at population studies, PCOS versus control women, a negative body image with 7 out of 10 subscales was associated with depression and reduced quality of life. So how do we relate this? In a research way, we use something called the health-related quality of life, and the most common one we use in PCOS is called the PCOS Q scale. These include 5 domains for emotions, body hair, weight, infertility, and menstrual problems. There's also a modified version for acne. And all of the studies look at this, show lower rates of quality of life for women with PCOS, and again impacted by the same things we've just talked about. The most striking moments are the infertility and body weight domains that impact on quality of life in PCOS. So we don't know about the phenotype in how it impacts quality of life, but it's likely very dynamic. So what might affect someone in their adolescent years may be very different to what impacts her quality of life when she is a young adult, and then again perimenopausal. And finally, disordered eating is very common in PCOS, and this is across all cultures. These disorders include anorexia nervosa, binge eating disorder. And so we refer to this whole general constellation of things as disordered eating. So they may not have specific diagnoses, but they may have restrictive eating behavior and binging behavior. Cognitive aspects of negative self-image that don't meet the criteria for strict eating disorder. So the prevalence of eating disorder in PCOS ranges in many studies between 12 and 36%. There is association with obesity as well as psychiatric diseases like depression and anxiety. So one of the things that we worry about with respect to PCOS worldwide is the delayed diagnosis and lack of information that we provide to women about their disorder when they seek care for it. So there's enormous opportunity for us as clinicians to help improve some of this anxiety. So this was a survey administered by the AEPCOS Society and asked several questions about it, but I want to draw your attention to 2 of them. Information about lifestyle management, things that we think are fundamental to managing PCOS, and emotional support and counseling after diagnosis. So in more than half of the women, they did not even have their provider ask them about their emotional condition, and the same was true, almost half did not give them any information about lifestyle. So as clinicians, we are not doing a very good job in assisting our patients if half the time the patient leaves the physician's office, this is worldwide, not just in the US, and they never got information about their emotional healing or their lifestyle therapy. So what about when we treat them? What is the impact? So we often use lifestyle treatments as a first-line therapy. And this was a small trial published a few years ago. And all groups that were enrolled engaged in diet and exercise, resistance exercise. They were randomized for short term. And they had about a weight loss of 8 kilograms. And they all experienced improvements in their PCOS-Q domains of emotion, weight, infertility, and menstrual score. This was a study that we completed out of our group where we looked at adolescent women who were treated for weight and lifestyle change, and half of them were given metformin in addition to birth control pills and lifestyle change, and half were given placebo. And it didn't matter whether they were on metformin or on placebo, just enrolling them in the program improved all of their domains across all of them. And as you can see, the most impact in our study was weight. The lower the score, the closer you are to 0, the worse your symptoms. So the lowest score at the beginning of this study was about their weight. They had very poor self-image, and that improved dramatically over just 24 weeks. And this was a study completed in the US, looking at women who wanted to become pregnant, so adult women, and they also used lifestyle, birth control pill, or a combination of birth control pill and lifestyle, followed by ovulation induction with clomiphene. And they looked for women who were becoming pregnant. And when you look at the depressive symptoms and anxiety symptoms, they improved only with the lifestyle therapy and only with anxiety. You see a slight reduction using lifestyle therapy in the depression, but really the birth control pills improved depressive scores more significantly than lifestyle alone. And here we see the PCOS-Q, and in red are circled all of the areas in each of the groups that improved after the therapy. So lifestyle program improved concerns about weight and infertility, and the birth control pill included also body hair. But when you put them together, both birth control pill and lifestyle, they all improved. So finally, the international guidelines, which we'll talk about more tomorrow, but specifically related to this area of emotional well-being. This was funded by the Australian government, and all of the groups, there were 6 working groups, including representatives from India who contributed. They will be rolled out 2 weeks, I think, at ESHRE. So the assessment tools that are going to be recommended by the international guidelines include things that are easy to perform and readily available. So there's an eating assessment tool, a patient health questionnaire, which is called the PHQ-9, and a generalized anxiety tool with GAD-7. So the questions we asked in the guideline committee was, in women with PCOS, what is the prevalence and severity of quality of life, and should we be assessing this? What dimensions are most effective, and what tools to use? So looking at the literature, these information comes back that really we should be aware, as we've all discussed, and that we should capture and consider women's perceptions of their symptoms, impact on their quality of life, and personal priorities for caring to improve patient outcomes. We should use the PCOS-Q if we feel comfortable with that to assess these. What about depression and anxiety? What is the most effective tool? Again, the recommendations from the guideline committee would be aware that there's a high prevalence of this condition, and it's likely increased in adolescents as well. We should be routinely screening all of our adolescent patients and our women with PCOS at the diagnosis of the disease. If the screen is positive, we should refer either within our own clinic or refer outside for a further assessment. And if treatment is warranted, psychological therapy and or pharmacologic therapy, as we talked about, should be offered to women with PCOS, but informed by the regional clinical practices where you are practicing. The optimal interval for anxiety and depression symptom screening is not known, but it seems like we should repeat this using our clinical judgment as patients progress through treatment and life events change. So some clinical practice points which will be in publication, so you can read that later, but there's simple questions that we are recommending that you ask. Initial questions over the last 2 weeks. Have you been bothered by the following problems? If any of the responses are positive, then we should further involve risk factors and symptoms, including the age and their culture and tools as we discussed earlier. And when we decide to use pharmacologic therapy, we should consider to avoid inappropriate treatment with antidepressants or anxiolytics. There are limited roles for this when women particularly are planning to become pregnant. But where mental health disorders are clearly documented and persistent, or if there are suicidal symptoms present, treatment of depression or anxiety should be informed by your local area. And we should be careful, as was mentioned in the panel, to avoid agents that exacerbate weight gain, because that's a significant problem for these women. And what about body image? What is the prevalence and severity of this? What tools should we use for this? And again, most of us, our women with PCOS, are right in the middle of this diagram. And if we go to the right, they become more eating disorders, more negative self-image, and we want to shift them to the left. And we do this with healthy diet and lifestyle and trying to infuse positive body images. So that's our goal. And again, the recommendations that we need to be aware, and again, we screen with simple questions. Do you worry about how you look and wish you could think about it less? On a typical day, do you spend more than 1 hour per day worrying about your appearance? More than 1 hour a day is considered excessive. What specific concerns do you have about your appearance? What effect does it have on your life? Does it make it hard to do your work or be with your friends and family? And once an issue is identified, we would then further focus the concern and respond appropriately to that. Again, looking for depression and anxiety in this as well. So disordered eating, again, very high prevalence in PCOS. And we should be aware, as the guidelines recommend, that we should be screening for this. And if we suspect it, we should refer for therapy, because some of these can be quite dangerous. And typically we use a screening tool, which is simply, does your weight affect the way you feel about yourself? Are you satisfied with your eating patterns? If there's a positive response, then we use risk factors and assess in our clinic as to what might be appropriate to refer to if we suspect an eating disorder. So in conclusion, there are psychological concerns such as depression and anxiety that are much higher prevalence in women with PCOS. I think it is safe to say it's 4 to 6-fold higher in women who have a diagnosis of PCOS versus women who do not have this diagnosis, irrespective of whether they are adolescent, trying to conceive, or in the perimenopause. Body image concerns in PCOS are associated with disordered eating, so we need to search for this because many of them will be trying to control their weight with very unhealthy eating patterns. And particularly if they are trying to conceive, this can be very destructive to your efforts to help them. We discover this quite often in women with PCOS as we're trying to help them with ovulation induction. Lifestyle interventions do appear to help with depression and anxiety. And again, the international guidelines recommend screening for all of these disorders with appropriate referrals as needed. So I want to thank you for your attention and your kind invitation.
And actually, the manifestations of the side effects of the depression was highlighted, and the Western world has actually developed a very objective kind of methodology, wherein each aspect has been nicely dealt with. It was actually a very wonderful talk. Any queries?
Dr. Kathleen, it was an excellent presentation, and the way you spoke, keeping up in mind the basic things that are to be dealt with, which we were not earlier looking for. And I feel strongly that this particular concept that has cropped up in this conference is going to help us a lot. As a gynecologist, what I feel is, because I have been hearing about the stress also, that you must treat the patient as you would like yourself to be treated for. And if that basic is kept in the mind, nothing will happen. And you'll be very, very nice and cooperative to the patients also. You don't have to relax, because the doctors are relaxed, all right, because they understand the problem. They don't have to go for any massage. They are themselves are looking after them, and they know it how comfortable they are, because when they're dealing with patients, they're not patients. You feel as if they are God sent. The God resides in you, and He has made you a doctor. So you have to be very sympathetic, especially with the patients who are coming to you with PCOS. As a woman, she has suffered a lot, and she will suffer throughout her life. And this PCOS is a very big burden on her head. Family is after her, the husband is after her, and when she is going to conceive, of course she is going to have happiness, she will have to suffer again. With that concept, I think it was really excellent, and I would like any questions to be asked.
One question, Kathleen, is that the objective type questionnaire which we have developed for diagnosing either eating disorder or anxiety, especially anxiety. Now, if you develop a questionnaire, is it followed with a score which you give, and then you know that, okay, this score is high and she requires more help? Is it something like that? What is the basic outcome of that? And secondly, if that questionnaire has been developed, should we as clinicians actively start making patients fill up this questionnaire? All PCO patients or selected patients, or how do you choose who fills it up?
So there are two ways that the guidelines approaches this question. The first is to simply ask, if you have these specific concerns. And if they acknowledge that they have some, then they would go to the next level, which is the general anxiety screening questionnaire, which there will be a link to on the guidelines. So anybody, it'll be open for everybody internationally to see, and you can download it. We in our clinic have our own, and we have decided, because in the US things are very often very pressured, and we don't have necessarily a lot of time with the patients because of the way our system is set up. So we have all of our patients, 100%, fill out the screening questionnaire, and we do have a cutoff. We have simply 5 questions, and they rate it in 5 different ways, which is it never affects me or it always affects me.
So that's a WHO 5
questions.
The WHO recommended 5 questions.
Yes.
The score of 5 is given
5,
from
yes.
1 to 5. So,
Correct.
so you think it's a good idea to let all the patients in the clinic fill it up anyways?
I think it is. I mean, it is not what the guideline will recommend, because every culture, every clinic will be different. Everyone should screen in their own way, but in our clinic, we find it's very helpful, because many patients, because it is so fast, sometimes they don't necessarily have that trust initially. So if you give them a questionnaire in their own time to fill out, they will tell you things they may not share face to face.
And before that, you said you can ask certain things if it worries them. Now, what are those questions which you ask? That means, are you depressed? Do you ask a direct question of depression, anxiety, or
Yes.
something, and then ask them to fill this up?
Yes. So some of the general questions we ask is do they feel anxiety? Do they feel simply in their own words? And that we do ask if they feel like they want to hurt themselves. We ask that specifically as well. We ask if they've ever thought about this, and if so, do they think about it every day or just infrequently? So we use some sort of gradations of that. But every patient is asked if she feels anxious or feels depressed.
So there you are. Every patient over there is asked about anxiety or her mental health. We don't do it. So I think it is high time that we, in our history taking for, I think, all patients, we should even ask, especially infertility, especially PCO young girls, whether it is there, and if we recognize it, maybe fill up that questionnaire. And the WHO 5 is available on the net. It is very easy to fill up. Maybe patients can do it, and we should start looking at this area anyway. Thank you.
And the bottom line is exercise, as you have suggested. Exercise is the best way
one of the methods to improve everything, including mental
by
health.
obvious reasons it helps.
Any further questions?
Like we have cancer support groups, can't we have PCOD groups so that they let out, मतलब अपनी मन की problems निकाल दें, they can talk to each other, patients with PCOD. Like we have cancer support groups. Like those have been treated.
Sir, my opinion is that which I want to give at that time also, कि we can't consult or we can't counsel the patient, every patient of the PCOS. But when we are taking a group of the PCOS and discussing the problem as a whole.
So we have a physiotherapist here who says that she can help these patients. Can you come up here and tell us what you can do for the patient?
Before the next question, I just have to make an announcement for the delegates. Because you have been joining, you have been here to attend the conference, but please do not forget to sign daily attendance to get the certificate. This for all the delegates, sign daily of your attendance at the reception to get the certificate. Thank you. Now you can continue with the discussion because everybody else is breaking for tea. We have half an hour time. The discussion can go on.
So I would answer your question, ma'am. Just like what ma'am was suggesting, exercise is the bottom line. So yes, but we don't have groups made for antenatal and postnatal exercises. So if we have those groups, you can also include in your working setup wherever you are, you can make PCOS or PCOD groups also. But because even in this stress management, people who exercise more are not stressed, or even if they're stressed, the exercises bring that down.
Ma'am, I am saying for the counseling by the doctor in a group.
You know, my point is that suppose I tell a young PCOD girl or this, you know, I have a session on Sunday, you come 9 to 11. You like this, but how many will come? How many? See, antenatal patients, I force them. My antenatal patients, I said, no, I'm not going to answer your questions on diet and exercise. Yoga, wo aake idhar class mein karne ka, I'm not going to answer that, so they're forced to come. PCOS,
Sir,
will they come? That is the question.
I have
She
made a
says
group
no.
of the
Lucknow mein
PCOS.
nahi aayenge. Nahi aayenge.
Sir, I have made a group of the PCOS, approximately 70 girls, and I am doing the counseling of those girls on a
But do they come?
They come.
They come for
still.
counseling.
Yes. They come. Approximately 60% are coming. 60 to
So I think we have to
70%,
make an
and
attempt.
that's
It's a
also
fair
very
attempt to
good
make,
number.
so they can even vent out their feelings. They know that they have got other people also doing it. So it's a good idea. Maybe we should try and look at it.
No, I just want to share an idea, because most of the times we need our patients to see a psychologist or a psychiatrist. Why don't we call them emotional healers, not psychiatrists? We change the word to emotional healers. Patient will more willingly will go to these people to get help.
I request all of you to read the ESHRE guidelines of PCOS. This chart regarding the mental health about depression and anxiety, and different questionnaire is provided in that, and that's a beautiful chart. And every patient, yes, every patient should be asked about depression and anxiety.
I wanted to give an input from the government hospital's point of view, the input from where I am working. There are loads of patients. There is no time for counseling as such. As I am the HOD, only selected patients come to me. So I realize if I have to see one patient, I need at least 1 hour. If I want to do justice to that patient, because you have to talk about the feeding habits, you have to talk about the daily lifestyle, apart from the treatment, examination and investigations, all those things. But actually you need to spend that amount of time. So what do we do in a government setup where we hardly have around 5 minutes time? That is a very good idea.
In the history taking, maybe we should have these 5 questions put so that everyone who fills up the history can at least ask the woman there and mark over there.
Excuse
Maybe
me,
that will be at least a start of this.
Kathleen, a question for you, please. How much do you go to the schools and look into the PCO situation? I mean, overweight girls with irregularities in periods. Do you catch them in the schools also, or wait for them to come to your clinic? And because a lot of times the delay is so much for the family to accept there's a problem and actually get in to get treatment, and if as a community, do you take them on? Because as such, we don't.
Yeah. So that's very difficult to do in the US also. So we can't go into the schools. We have to be referred. The way our system works, we have to have a physician referred to us, because we are specialist physicians, and in the US you can't just walk into a specialist office, or we can't go out and talk to them. When we do our research, that's what we do, because we have permission to do that. But that's a different, not in the clinical world. So when we are recruiting for a study, we are allowed to do that. But parents need to be aware. So what we try to do is work with the gynecologists, the general gynecologists, and they're very well aware of what resources we have, and we tell them, if you're seeing a patient and she has a daughter and she brings up a question about her daughter, make sure you know either to see her yourself or send her to our clinic, and that's how. But it's a good question.
I think the PCOS is a very complex issue that cannot be dealt with in an ordinary OPD that is being conducted in the government hospitals. In the medical colleges, we have got the residents to help us, and in that way you have to organize and start working in that fashion that a detailed history of a PCOS as the patient is concerned is taken, because you have to chalk out so many things, the diagnostic procedures, the features where you have to send it, what is to be done, what is not to be done. If that is a thing, that you have to have that type of stuff. Thank you.
Well, maybe I can share what we have in Canada. It's also, physicians are too busy. We had a patient a few years back. First of all, I have to mention that Canada is a country of immigrants. And you might not have this problem here, but a few years back, we have a patient with infertility and PCO. Her second visit to the clinic, and she was told that her chance is not very good. she answered all the questionnaires, whether she understand or not, we don't know. On Sunday, the police found her hanging from the 6th floor of apartment building. So I just want to mention that there are other factors that might also cause these kind of things.
Hi, Kathleen. In your, yeah.
Please no more questions.
You also said that when the studies were done about satisfaction rate of the patients, they said that a lot of their clinicians have not talked to them about lifestyle modifications or diet. How do you do this in your clinic? Do you sit with them and do you do them, or do you give a referral to a dietitian and an exercise person?
So we have a specialized clinic. We'll talk a little bit about that tomorrow. It is recommended, if it's possible in your community, to have a multidisciplinary clinic. So my clinic in the US has both a counselor and a nutritionist, and we all see the patient together. So when they come, I speak with them and we talk about their medications and we talk about how we might prepare, whether they're going to have a baby or they just want to control their symptoms, and then I have them meet simultaneously with the nutritionist and the counselor. So it's a nice luxury to have all three, and then we have a dermatologist that they can see as a secondary level. So, but that's very unusual in the US, although it is the best way, I think, to arrange it. And I think for those that don't have those options, then you have to use very quick screening tools and maybe refer. That's a little less efficient, but probably a very important way.
And again, when they have to go to somebody else and take out another bit of their time, the compliance comes down.
Yes.
They
I
wouldn't
agree.
go, they wouldn't pay.
Right, exactly. So we found that it's most efficient to have them
So you
one
have
clinic
everybody
and
under
then
one roof.
we have the providers in the clinic. And that's what's recommended in the international guidelines we'll talk about tomorrow.
And they pay once, the insurance pays once for the whole.
They pay once for each of the physicians, and then they have a supplemental payment if they see the nutritionist. So they can be billed twice in one visit.
Okay, thank you.
I think that private and public run medical facilities can be different. I'm sure that in this society, PCOS Society of India, has members from the medical colleges. Then they can establish the multidisciplinary clinic. This is what we have been advocating for a long time. I can understand in a private practice there could be a conflict and may not be so easy to do. But if this starts in all the medical colleges throughout the country, whether it is government supported or the municipalities supported, that should be advocated by PCOS Society of India. Madhuri.
Yeah, actually we can advocate, but I think in medical colleges it really becomes difficult because no, they aren't, I mean, they have too many patients. If you tell them something that you can establish a clinic, they said, no, we have too many patients, that's not possible. And at a single time, I mean, you cannot send one patient from one OPD to the other and other to other. So you should all have it in the same place and where they run the PCOS clinic. But this concept of having a PCOS clinic itself is a little difficult because people just want to do what they are doing. They don't want to do extra, and especially when it comes to government medical colleges. So it has to be a very good initiative for us, and we have to make sure that we put into them the need of the hour of starting a PCOS clinic.